Welcome back to MLT 130. Today we're going to be doing the lecture on NPN substances, which is non-protein nitrogenous substances. And the four products that we're going to be discussing are urea, creatinine, uric acid, and ammonia. This lecture will be following along with an outline that's available on Moodle that I would encourage you to print before going any farther along in this lecture video. So what are NPNs, or non-protein nitrogenous substances? These are the breakdown products of catabolism of proteins and nucleic acids that contain nitrogen but are not part of protein molecules. In a patient with normal renal function, the kidney removes non-protein nitrogenous substances from the body. The first NPN product that we're going to talk about is urea. It is the one that is highest in concentration in the body. It is produced in the liver from ammonia and from the deamination or breakdown of amino acids. Something of note is that amino acids from protein catabolism become ammonia. Then the liver converts ammonia to urea, and we excrete the urea in the urine as a waste product. And remember that's going to be helpful in answering a question a little bit later on in this outline. Urea is the major excretory product of protein metabolism. Normal urine has urea. Urine is made up of about 95% water and about 5% salts, and of that 5% salts, it is mainly urea. So urea is the most abundant solute or solid in urine, and water is the most abundant liquid. Urea in the blood is filtered by the kidneys, and then about 40% is passively reabsorbed. Thus, we measure what is called the BUN, which is the blood urea nitrogen in the blood. The normal range for the BUN in plasma and serum is anywhere between 7 and 24 milligrams per deciliter. The term azotemia means there's increased urea in the blood plasma. Uremia is increased blood urea, a condition that is seen in renal failure. If the kidneys are not fully functional, the BUN is increased, but there can also be non-renal factors that can cause an increase in your BUN. Azotemia, or increased BUN, can be classified into three categories: pre-renal, renal, and post-renal. There's a nice chart in your textbook on page 264 in box 11-3 if you would like to look at these different causes. Pre-renal causes occurs before the kidney due to reduced blood flow in the kidney. Examples are dehydration, congestive heart failure, and shock. Renal causes include decreased renal function. Post-renal causes include obstruction of urine flow due to one problem or another. It is possible for a patient to have decreased BUN, but not as common to have increased. Causes of decreased BUN are decreased protein intake and severe liver disease. So we have a question. Why could severe liver disease cause a patient to have a decreased BUN? So think back about what we said earlier on about that note about amino acids and the protein catabolism and ammonia. It's because the liver converts protein and amino acids to urea. So the liver is not functioning, then the blood ammonia is increased and the urea will be decreased. We can use the calculation or a calculation to determine the urea concentration from the BUN. It's BUN times 2.14 equals the urea concentration, and it gives you an example here. And the example is the BUN is 27, and you would multiply it times 2.14, and the urea would be 57.8. The analytic methods for measuring urea is the hydrolysis of urea by urase. Then you're going to quantitate ammonia. The specimens that you could use are plasma, serum, or urine. You do not want to use citrate or fluoride, and fasting is not required for these specimens. The next non-protein nitrogenous substance we're going to talk about is creatinine. Creatinine is synthesized in the liver and is a waste product of muscle metabolism. Creatinine is released to the blood at a constant rate proportional to muscle mass, and then excreted in the urine. If renal function is diminished or decreased, then blood creatinine will be increased. Creatinine is filtered by the glomeruli in the kidney and does not undergo any significant tubular reabsorption. Thus, we can use blood creatinine levels to evaluate glomerular filtration rate, or the GFR. So what are the normal ranges for creatinine? For males, it's 0.9 to 1.2, and females, it's 0.6 to 1.1. Why the difference in the males and females? Well, males typically have more muscle mass. Creatinine levels are also decreased with age and as muscle mass declines. Serum creatinine is a very specific test to measure renal function. However, about 60% of renal capacity has been lost by the time the creatinine has become increased. Because urine creatinine decreases as serum plasma creatinine increases, we can use a more sensitive test called the creatinine clearance test to detect glomerular disease. There's 3 reasons the creatinine clearance is a better indicator of glomerular function than the blood creatinine alone. It is freely filtered by the glomeruli. It is not reabsorbed by the tubules for any significant extent, and it is released into the plasma at a constant rate. So a decrease in the creatinine clearance indicates diminished renal glomerular function. For us as lab techs, to perform a creatinine clearance test, the patient must collect a 24-hour urine specimen, and also there must be a specimen, a serum or plasma specimen drawn during that same time frame, that 24-hour time frame as the urine collection. The 24-hour urine volume must be measured. An aliquot of the urine from the 24-hour specimen must be analyzed for creatinine, and the patient's serum must also be analyzed for creatinine. The results are then plugged into the following formula. U times V over B times T. U represents the urine creatinine, V represents the volume of the 24-hour urine in milliliters, B represents the blood creatinine, and T represents time in minutes. And there's 1,440 minutes in a 24-hour period. So let's look at an example for the creatinine clearance formula. The patient has a 24-hour urine volume of 1,600, a urine creatinine of 130, a blood creatinine of 4, and of course we're going to use 1,440 minutes because that's how many minutes are in a 24-hour period. So if you plug that into the equation, the 133 is going to go in the place for the U, the urine creatinine. The 1,600 is going to go in the V spot for the volume. The 4 is going to be in the spot for the blood creatinine, and then of course the time in minutes is going to go in the T spot for the minutes. If you calculate that out, this patient's creatinine clearance is 36.9 milliliters per minute. The reference range for males is 97 to 37. For females, it's 88 to 128. Anything less than 50 milliliters per indicates moderate renal impairment. So this patient at 36.9 thus shows moderate renal impairment. Something to note with the creatinine clearance: if a person is very small or with kids or very obese patients, the body surface area might need to be included or used to correct the result. In many labs, the creatinine clearance formula is used to is used by the provider, but it is corrected if the patient is not of average weight. For The creatinine methodologies, know that it's referred to as the GAF reaction, and know that the reagent that's used is picric acid, and that there's a color change to orange. For the specimen, fasting is not required, and you can use plasma, serum, or urine for creatinine testing. Also, something of note, providers usually order both a serum BUN and a creatinine together to check the renal status. These tests are both usually included on a basic metabolic panel or a BPM and a comprehensive chemistry panel or a CPM. They both should correlate. If the BUM is high, usually the creatinine is going to be high. However, the BUM can be influenced by factors such as a person's diet or dehydration, and the creatinine is not. So alone, creatinine is a better test if you're just going to do one. The third non-protein nitrogenous substance we're going to talk about is uric acid. It's the final breakdown product of our nucleic acids such as DNA and RNA. Most uric acid is formed androgynous from cells being broken down and replaced. Most uric acid is excreted by the kidneys as a waste product. We usually test our plasma or serum for our uric acid. Hyperuricemia is an increase in uric acid in the blood, and that's usually greater than 7.0 milligrams per deciliter in males and greater than 6 in women. The primary cause or reason of increased uric acid is gout, but there can be other causes which include renal disease and leukemia patients and cancer patients on radiation and chemo. There's also a condition called Leishman, which causes an enzyme deficiency. Gout, which most of you are probably familiar with, is a condition where painful uric acid crystals, which are also known as monosodium urate crystals, form in the joints. Most common in males, but this can also happen in females. It's usually treated with a medication called allopurinol. Patients can also develop renal calculi, which is kidney stones, composed of the uric acid. On the flip side of that, you can have hypouricemia, which is low uric acid, and this is less than 2 milligrams per deciliter. Our specimens that we usually use for uric acid include heparinized plasma, serum, and urine. Two methodologies we use to measure uric acid include phosphotensic acid and uricase. The fourth and final non-protein nitrogenous substance we're going to talk about is ammonia. It's developed from the deamination or breakdown of amino acids in the intestinal tract, normally metabolized in the liver to urea, and then urea is excreted by the kidneys. In liver dysfunction, the liver is not able to convert excess ammonia to urea. Patients with advanced liver disease have increased ammonia in blood, and high ammonia blood levels are neurotoxic for the patients. Patients may go into hepatic coma if ammonia levels are too high. So in the laboratory, if we do have a high ammonia, they're usually called as a critical value. Conditions that cause advanced liver disease include acute viral hepatitis, Reye syndrome. If you think back, Reye syndrome is a metabolic disorder. It's rare, but it can cause swelling in the brain and can cause confusion and liver damage. Remember, this is the syndrome that usually kids start out with a virus and they end up taking baby aspirin and they end up with the Reye syndrome. Also chronic hepatitis, also problems with drug and alcohol abuse. For testing methodologies for ammonia, the method of choice is an enzyme assay, glutamate dehydrogenase. The specimen is venous blood, or you can use EDTA or heparin, obtained without trauma, and you want it to be the sample to be put on ice immediately after collection. and you want to centrifuge also at refrigerated temperatures between 0 and 4 degrees Celsius. Must test within 20 minutes of collection, and you want no hemolysis of the specimen. Cigarette smoke and detergents can also contaminate the specimen. This concludes our lecture on non-protein nitrogenous substances, and I will see you over in the next lecture.